Good afternoon. Going to give everyone a couple of minutes to trickle in. Hello, hello. Good afternoon. Okay, I'm going to go ahead and get us kicked off. So for those that trickle in, hopefully you know that you are in the right place. Good afternoon, everyone. If you're expecting to be joining Sam Houston State University's College of Osteopathic Medicine for some CME, then wonderful, you're in the right place. And if not, stick around anyways, get some CME credit, and maybe you can learn a thing or two. Today, we are joined by our presenter, who is our very own Dr. Mary Hogan, who serves as our Director of Clinical Education. She earned both her MBA and PhD in Demography and Public Health from the University of Texas at San Antonio and the University of Texas School of Public Health. She has worked in senior leadership for the University Health System and Baptist Health System for over 18 years and has taught for the School of Health Administration at Texas State University. Dr. Hogan began her first role with the medical school in 2016, serving both in their administration and as a professor, until we were fortunate enough to bring her here to SHSUCOM last year. Her presentation today is titled A Day in the Life, and as it suggests, will provide insight into your role as a teaching physician while positively experiencing the benefits of having medical students join you. So I'm going to go ahead and hand it over to Dr. Hogan, and then I'll provide instruction at the end for how to claim your credit. But otherwise, without further ado, Dr. Mary Hogan.
Welcome. Thank you so much for joining us today. And if you're not currently a preceptor with us, we'd love to explore the opportunity of you precepting our third and fourth year medical students. Our third years will start their rotations on August the 1st, so I'll use that as my initial introduction. So this will be about the day in the life of both the student and you as a preceptor. And the basic objectives of this presentation, you should be able to understand the role of teaching as a physician and to students, utilize the techniques that save time while providing educational opportunities to the medical students, and become aware of patient responses to medical students in the clinical environment, and appreciate the medical student documentation and its role in patient care. Then we'll go through how to create a positive learning environment for the students while meeting patient needs and their satisfaction. And last, realize the benefits of teaching, being a teaching physician, participating in the education of future physicians. So I've got a couple of questions for you, and we're going to do a quick poll. How many of you have had to supervise medical students or trainees in the past?
And I have just launched that poll. So you're actually going to see all three questions at once, and I'll give you all the opportunity to respond to it. And then we will display those answers as soon as everyone has had an opportunity to participate.
Okay. And then how many of you have had formal training in teaching? And it looks like none. And then what is the biggest challenge you face as a preceptor? So we'll go through those. It looks like we've got a great opportunity here because all of you have supervised medical students or trainees, but you haven't had any formal training. And the biggest challenge is lack of time, which we regularly hear that lack of knowledge, lack of trust, discrepancies in applying theory to practice. So the biggest one that I hear regularly when we are recruiting also is that lack of time. And we're going to go through how we can better address that in the future. Okay, so teaching in the clinic should not decrease your productivity. It should actually help increase your productivity. We'll go through later in the presentation how to do that. And then teaching can bring back some of the joy in medicine. If you think back on when you were a medical student and that first interaction that you had in your third year doing those clinical rotations, how connected you were with those that did a really good job, and the memories that you have of those that probably were not the better preceptors. And it's also an opportunity to give back, as we've all had mentors that have encouraged us in our medical education. And also being involved in medical education can remind you of why did you want to become a physician. And as you are preparing to precept, it might be helpful for you to also think back on your internship experience and remember those that you felt like had some really positive traits, and those that may not have been had the more lasting positive impression on you. And what should the model of the most constructive preceptor look like and the student relationship look like? Okay, preceptors and medical students. Students can do research on difficult or interesting cases. With current technology, students can be enlisted to help find current guidelines and articles at the attending physician's request. This is also a great opportunity to use the point of care tools to enhance evidence-based medicine. The students all have access to over 3,000 journals, and so if they need to do some more research, the information is definitely there. And they can be given assignments and time to do them based on what they see during their patient care experience. Medical students can review diagnostic tests and report abnormal findings to the attending. This can be a great opportunity for them to really learn on some more interesting cases that are a little different. Also, medical students do not need constant attention. Medical students are adult learners, and they should be encouraged to employ both self and peer-to-peer learning. Peer-to-peer obviously is when if you do have two students that on each rotation, this helps in that process, especially with different supervising physicians. And then another opportunity is for medical students can see patients that take up excess time. I know you've all had patients who have long histories, and they can be seen by the students, obviously with the patient's permission. And this can abbreviate the time that you may need to spend with the patient. Patients also like that the student can listen to their story and can give them more time than you may be able to. And it's also a good learning opportunity for students to learn and listen and form a comprehensive report. Students can see patients and document them. Students should be given patients to see while attending, while you continue throughout your workday. And they should be given the option to have, patients should be given the option for the student to see them before you would actually see them, and the students can see patients in advance of their attending's presence. Students can also help by providing documentation in the patient record. Excuse me, in 2018, CMS changed the rule allowing physicians to accept documentation by medical students. This is part of the claims reviewing manual to allow the attending to verify rather than redocument. And the teaching physician does actually have to personally perform or re-perform the physical exam and medical decision-making activities to be able to bill for it, but it's really a verification of the documentation that the medical student record rather than redocumenting the work. This allows medical students to be helpful in completing that documentation. Patient satisfaction. There's a study that is listed here in 2020 that was done at the University of Minnesota that showed greater patient satisfaction if the student participation was there, because their providers' knowledge of their personal history and their providers looking out for their best interests. So it's that they have two eyes and ears on them as a patient. In addition, we found that the Press-Ganey scores do not go down for ED visits, and the patient acceptance of a medical student participation is largely the desire to contribute to the education of others. And nonetheless, all patients have the right to know if the student is participating, and it is a voluntary participation. So, attending role in the patient perception, the attending physician can have an impact on the patient attitudes towards student participation. It's important to define the role of the student to the patient. So you need to obtain first the consent of the patient prior to the student entering the room. And this can actually be done by a staff person, not necessarily yourself. And you're going to describe the level of oversight that an attending will have over the students, and provide a positive view of the medical student participation in their care. Next, identify the advantages of a medical student. Patients typically get more time with students than attending, and patients also, as I mentioned earlier, get two sets of eyes reviewing their case, as well as students can perform a more thorough physical exam, and academic activity can raise the level of care and keep the practice more current. Next, effective clinical teaching issues. 40% of physicians report having experienced mistreatment in medical school clinical rotation. So kind of reflecting on your experience, 40% of physicians today report some mistreatment that they had by an attending during their clinical rotation. So we are going to look at an acronym called the KIND framework for clinical teaching, and it avoids this misperception. The source on this is UC Irvine. First one is knowledge sharing, and this is the provision of specific facts to be learned rather than vague direction or personal criticism. The next one is inclusive, so it's active engagement of students as members of the healthcare team. It's next for the N, non-discriminatory. So this is mindfulness of unconscious prejudicial treatment on gender, ethnicity, sexual orientation, or personal beliefs. And the last one is developmentally appropriate. So it's important to adjust one's teaching and expectations based on the student's academic level and prior experience. Remember, they're not yet physicians, but they are beginning third year versus end of fourth year students. So top 5 human characteristics are communication skills. The emphasis of medical education has shifted from a didactic knowledge-based model to an acquisition and application of skills through experiential learning, active engagement, competency-based skills. So an effective clinical education should integrate the training on diverse medical topics, critical thinking, clinical education, and communication skills. Act as a role model. The preceptor plays an important role in the educational process and development by monitoring and guiding their learning experience while acting as a role model. We all know how discouraging people are who are unsatisfied with their jobs. Sometimes negative attitudes do not even have to be voiced. Negative attitudes have a way of rubbing off. A preceptor that encourages questions is providing an environment where the student can comfortably make sure they're getting it by asking questions. And at the same time, preceptors with this trait are perceived as patient and supportive because of their encouraging attitude. It's hard to be encouraging without also being patient and supportive. On the other hand, a preceptor who asks intimidating questions or acts superior or intimidating is not encouraging questions. An effective preceptor will minimize stress by being patient, encouraging, and supportive, but also have high expectations. Next, personable. It's important that that student feels that they have a relationship with you, and that is one of being down to earth. Compassion. Compassion comes from the Latin word, which means co-suffering. In psychology, compassion is regarded more like an action rather than an emotion. It involves elements of empathy, love, and care. And compassionate expressions aim at alleviating the troubles of others or sharing them with the sufferer. Next, an ideal approach, as one would guide, uses teach medical knowledge, second, clinical skills, and diagnostic reasoning in inpatient, ambulatory, and other educational venues. Actively engage learners in activities that promote synthesis and analysis and data, and generation of knowledge through struggle or risk-taking in a non-judgmental environment. And then next, evaluate core competencies required of the learners, including clinical year medical students. An effective method should permit the clinical preceptors to bridge educational theory and clinical skills training by means of time-efficient, context-aligned, flexible, and dynamic preceptor, learner, and patient interactions. Critical that all three of those work. So some of the pitfalls of case-based teaching are where you take over the case, there's inappropriate lectures, there's insufficient wait time, so 3 to 5 seconds before they answer, but pre-programmed answers, so allowing a hands-on experience. This can be a really difficult one for preceptors. However, students cannot internalize the role of a physician if they are not allowed to practice it. Conversely, only being allowed to observe is often listed as the biggest frustration of supervised practice experience. You will see when you reach the section on teaching skills that most experiences begin with observation, but those that go no further do not provide an optimal learning experience. And it takes confidence in the student as well as confidence in the preceptor's own ability to allow the student to actually perform tasks when a mistake could be made. So bedside presentations. Doctors, improving bedside presentations, patients should be given the opportunity to say more. Allow physicians in the room, they should introduce themselves along with the students. They should be more attentive, and there should be fewer people in the room. The physician should respect the patient's privacy. They should ask permission to present at the bedside, and when appropriate, the physician may want to be seated in a chair adjacent to the student and the patient. So modeling. Modeling is demonstrating a skill or process while thinking aloud, so that the student can witness the thoughts or problem-solving process of the preceptor, as well as the observational skills. For example, the student observes a preceptor develop a medication therapy regime and monitoring for an asthma patient, while the preceptor simultaneously explains the thought and problem-solving process that would normally go on silently. But the student sees and prepares to emulate the modeling examples. Patient observation. An example of this is after the student has acquired the necessary background information and observed the preceptor model of development of a medication theory regime that we just discussed and monitoring plan. The preceptor allows a student to develop a regimen of and monitoring plan for another patient and asks the student to think aloud so the preceptor can observe the student's thoughts and actions, and then the preceptor reflects back with feedback during that process. The preceptor role is appropriate after the student has had the opportunity to observe the modeling process and he or she is about to take on but is not yet ready for independence. This coaching process allows fine-tuning for the student's skills, as well as assuring the preceptor that the student is ready to move to a greater point of independence. When the preceptor no longer feels the student needs to provide, or they no longer need to provide a corrective feedback to the student while they perform the task at hand, it's time to move to the next preceptor role of facilitating. Okay, I don't know how many of you have heard of this book, but it's the 5-step micro skills of clinical teaching. I always like to reflect back on this, whether we're talking about precepting or other parts of my life. It's a good intention with a bad approach often leads to a poor result. Thomas Edison. So this 5 micro skills of clinical teaching is a great model. In summary, this practice technique is composed of 5 consecutive micro skills or steps. It's based on many of the principles of adult learning. It's a great technique to use when you're teaching one-on-one or when time is limited. It's also called the 1-minute preceptor. So first, get a commitment. What do you think's going on? Second, probe for supporting evidence. What led you to that conclusion is frequently the question with that. Teach general rules. So another question with this is, when this happens, do this. Reinforce what is right. Specifically, you did an excellent job of, and then fill in the blank. And corrective mistakes. Another way to phrase this one is, next time this happens, try this. So to getting into a little more detail, on micro skill 1, getting the commitment, this step is necessary when your learner either waits for your response or asks for your guidance. Second, some helpful approaches with this are you want to learn what they're thinking about in the case. An example of questions likely to get a commitment are, what do you think is going on with this patient? Why do you think the patient has been non-compliant? What do you want to do next in the workup? What do you want to accomplish during this hospitalization? Examples of questions that are likely to not get a commitment are, sounds like pneumonia, don't you think? Anything else? Did you find out which symptoms came first? So micro skill 2, First one, this step is necessary when your learner either waits for your response or asks for your guidance. So once the learner has stated his or her opinion, you want to avoid your instinct to tell them whether you agree or not. Instead, ask questions to find out the reasoning behind their opinion, such as their knowledge may not be evident before this step. So you're taking the opportunity to evaluate them while allowing them to think through the case. Some helpful approaches include what are the major findings that led you to your conclusion would be a question you'd ask of the student. What else did you consider? How did you rule out that choice? Some non-helpful approaches, I disagree. Do you have any other ideas? Or this seems like a classical case of, or when you state what were her vital signs. Micro skill number 3 is to teach the general rules. Once you've evaluated what this learner needs to learn about, you can use this opportunity to provide the learner with some general concepts or principles related to the case. The learner can apply these concepts to other patients in the future. And some helpful approaches with this are, for example, if the patient only has cellulitis, incision and drainage are not possible. You can wait until the area becomes fluctuant to drain it, or patients with UTIs usually experience pain with urination, increased frequency and urgency. The urinalysis should show bacteria and white blood cells and should show bacteria and white blood cell count, and may also have some RBCS. Non-helpful approaches may include the patient has heart failure and needs diuresis. Don't start the beta blockers now. And I'm convinced that to diagnose cellulitis, you need an aspiration for culture. Fourth, make sure that you want to let the learner know specifically what corrective or what was correct and effective. Some helpful approaches with this can include that you did a very thorough job evaluating the patient's abdominal complaints, or identifying the combination of anemia and blood in the stool was critical in making the diagnosis of colon cancer. You considered the patient's finances and your selection of drugs, and your sensitivity to cost will likely contribute to his compliance. Some non-helpful approaches might be, you're right, that was a good decision, or just nice presentation. So the difference here is that you've provided some specifics between the helpful and the non-helpful approaches. So correct mistakes. In this case, you might want to let the learner critique him or herself first, then offer your specific observation and ideas for improvement. Some helpful approaches may be that I agree that the patient is probably drug seeking, but we still need to do a careful history and physical exam before we make any recommendations. Non-helpful would be something like, you did what? What were you thinking? So in closing, trainees do not perform required skills incorrectly on purpose. Errors in performance are typically the result of insufficient feedback. They seldom are the result of insufficient interest or caring. So we are very excited to have our students start their clinical rotations on August the 1st. Dr. Stephen McKernan is the Associate Dean for Clinical Affairs, or myself. We're available for any questions, help, tips. I include my cell number on here because just as in many cases, it's better to address any issues that may come up sooner rather than later. And if you have any questions now, I'm here to do that. Otherwise, Sarah will follow up with you on how to close the CME. Thank you for joining us.
Yes, thank you all so much. If you do have any questions at this time, you can use the Q&A feature in the webinar, and I will monitor that should something pop up. I'm going to go ahead and put in the chat the assessment link. And once you complete the assessment, it will take you directly, there will be a thank you message and it will link you to your claim credit. I will also send an email first thing in the morning with this information as well as the presentation. So if you have any questions, that's my direct contact. If you need anything, I also do want to plug the rest of our CME for this term. All of it is going to be relevant to your precepting. And based on the feedback that you all have provided us, we offer them at the same time every month. It is the second Thursday from 12 to 1 o'clock. And hopefully you're getting all that information. But if you have any questions, I'm your person for that. Let me know. And if there's anything that you're really interested in seeing, or if you want us to come to your site to offer it, you can also get a hold of me and let me know that as well. But I don't see any questions. So with that, I hope that you have the link and I hope you have a wonderful rest of your afternoon.
Thank you.
Okay, I do see a question. I do see a question in here, which Dr. Hogan has already popped off. So I have this person's information. I'm going to have Dr. Hogan email you and get back with you on that. Thank you so much for your question in the chat.